Good evening, everyone. We welcome you to the monthly Wincars Association PG teaching program. The agenda for today's meeting is approach to acyanotic heart disease. We are very glad to have Dr. Snehal Kulkarni ma'am with us. She is a senior pediatric cardiologist. She is chief of pediatric cardiology services at Fortis Hospital, Mumbai, and she is also visiting pediatric cardiologist at BP Wadia Hospital. We welcome you, ma'am. Thank you for joining us. We have our own Dr. Jyotsna, ma'am, president of Wincars. In spite of having ma'am is writing a Sanskrit exam, and though she had to prepare for the exam, she wanted to join for some time. Thank you, ma'am. Thanks for sparing your time. We have Dr. Namita, DNB cardiology resident from BP Wadia Hospital, who is going to present the case. And we have Vijay Lakshmi Madam, a senior pediatric cardiologist, HOD of pediatric cardiology at Jayadeva Hospital previously. And I'm happy to say that I was her student during my training period. Welcome, ma'am. Shall we start the session? Dr. Namita, are you ready for presentation?
Yes, ma'am. Can you see the screen, ma'am?
Yes, your slides are visible.
All right, ma'am. I shall begin then.
Yeah.
Good evening, everyone. My name is Dr. Namita Banerjee, and we shall start with today's case presentation. So, a 14-year-old male child who was second by birth order, resident of Mumbai, a known case of some congenital heart disease, was brought to a hospital by his father with a chief complaint of breathlessness on exertion since the past 2 months. In HOPI, the child was apparently all right 2 months back when he noticed that he would develop some breathlessness on exertional activities as compared to his peers. This breathlessness was amounting to NYHA class 2 severity and was gradual in onset, non-progressive. Breathlessness was reduced on rest and had no other aggravating or relieving factors. There was no such complaints that the child faced on lying down. No other chief complaints were present. In negative history, the child did not have any history of repeated lower respiratory tract infections or hospitalizations, no history of edema, no history of bluish discoloration or cyanosis, no history of persistent fever, no history of joint swelling or pain, no history of any syncopal episodes, or no history of palpitations. In past history, the child had a significant past history at 6 months of age when he had an episode of respiratory distress and fever for which he had to be hospitalized for about 15 days. During the same hospitalization, because of hearing an abnormal heart sound, the patient was evaluated and diagnosed to have some congenital heart disease. He has been on regular follow-up for the same, but not on any medications. In other history, the dietary history, the patient has adequate calorie and protein intake, normal immunization till 10 years of age, and average scholastic performance.
Hello. Now, Namita, just wait.
Yes, ma'am.
How do you summarize your history?
And this, according to me, ma'am, this child is known case of some congenital heart disease, likely to be not very significant since he did not have any symptoms and he's on regular follow-up. Most probably some shunt physiology or some mild obstructive lesion could be.
So why do you say it's a congenital heart defect? Because he's a 12-year-old boy. It can be an acquired one as well, isn't it?
Since he has a significant past history, according to that, and because of he was diagnosed at 6 months of age.
But was there any history suggestive of a large shunt or a failure to thrive or difficulty in feeding?
No, ma'am.
There were episodes of pneumonias and all?
No, ma'am. There was no significant history for any failure to thrive or any repeated admissions.
Usha, can we just see what others feel? What can be a possible diagnosis at this stage?
Before we go for the diagnosis, possible diagnosis, Namita, I want you to analyze your history itself. Yes, each complaint, unless you analyze, you will not come to conclusion. Okay. Why was the child admitted and what was the diagnosis at that time? So you can't say that the child was totally normal. At the age of 6 months, if the child is admitted in NICU or ICU, what was the condition at that time? Was it pneumonia, lower respiratory infection, or was it anything else?
I think it was a lower respiratory tract infection
Okay,
that necessitated probably oxygen or some support. Hence, he was
okay,
admitted
okay,
for the same.
okay. So, what do you attribute that episode of admission as?
Since it is an isolated event, I would suggest that it was an incidental finding during that episode.
No, you can't call it as accidental. You can say incidental.
Incidental.
Okay, incidentally, the child was admitted. So at that time, what were the treating doctors' advice? What did they do?
During that time, because he was diagnosed then and diagnosed to have the heart disease, however, they felt that it was not very severe. They advised
No, he was diagnosed to have as a congenital heart disease, right?
Yes, ma'am.
So that means it is not acquired. Okay, straight away you rule out the acquired. So the patient had a congenital heart disease at that time. Over that, acquired heart disease can come. That's a different issue. But here there was a congenital heart disease, and they said there is no emergency to do any surgery or any treatment immediately.
Yes,
isn't it?
Yes,
That's what they advised. That means either it is a moderate one or it was a small one. So whatever the lesion was there, it was moderate or small. And since there was no cyanosis, you rule out the complex congenital. So it is acyanotic. So acyanotic congenital heart disease presenting at the age of 6 months. What are the conditions that you think of?
Another thing, Namita, I just want to ask you,
Yes,
when do you call it as a significant respiratory infections because of fluctuations?
when there are repeated
Repeated meaning how many? Like there is a definition when we call it as a frequent chest infection, which
more than 5 in a year.
no, it's not more.
No. You are telling the wrong one.
It is not 5. It is more than 3 which need hospitalization. So that is considered as a significant like problem of repeated chest infection. It's not 5, it is 3.
3. Okay.
Namita, you must go for the IAP definition. So IAP has technically given a changed one. Like previous to 5, 6 and all gone. So even if 2 are admissions per year is significant. Because that means it's just not the upper respiratory. It is a lower respiratory requiring admission is enough. Okay. So the child was admitted once. At that time itself, it was diagnosed to have as a congenital heart disease. So what do you think is the possibility?
I feel
Vijaya Lakshmi, there is a opinion poll and then we discuss the different
Okay,
things.
sure, Snail.
And anyone who has any DDs can type in the question answer box.
No, before we go to DD,
question?
I thought we can discuss at this moment from Namita herself,
No, but then the all the people will know what is the diagnosis. Therefore, I want to test.
No.
That is the thing. Yeah. Let them see, and
you are a very strict. Snehal, you are a very strict examiner.
No,
this
it's
is
not like
teaching.
that. Because they will get every clue and they will come to a right diagnosis. Therefore, I just want to know what is everybody's opinion pool, and then we'll discuss with Namita the possibilities.
Monica, can you show the first question for audience poll?
So there are 2 kind of a sets of questions. Yes, with this kind of a history, what are the possibilities with the history? Whether it is small VSD,
small VSD, small ASD,
mild valvular pulmonary stenosis, mild valvular aortic stenosis, all of above or none of above. Okay, are we done, Usha?
Shall we end the poll? Yeah, I'm going to end the poll. Yeah.
I'm very surprised why somebody said why mild aortic stenosis was not a possibility and none of above also was a possibility.
Yeah, the bicuspid aortic valve is a very common one.
Yeah, why
So-
not that?
so-
And why none of
Yeah,
above
that's the
also?
common. And any child can have a respiratory infection, so that could be an incidental finding. That could be one possibility.
Yes, yeah. So it may
Then
be
pulmonary
anything.
stenosis, will they have respiratory infection? No.
It may be just the child has pneumonia, which many children have pneumonias at this time. And as Dr. Vijayalakshmi said, this was an incidental finding that somebody detected a murmur because apparently the child was very well till 12 years of age. He never had any complaints of failure to thrive. He was going to school, doing all his regular activities. So whatever lesion they might have suspected that time might have been a milder lesion, not a very severe lesion. So anything is possible. Small VSD is possible. ASD is possible. Valvular stenosis, pulmonary stenosis is possible. Mild valvular aortic stenosis is possible. In fact, I would have said
Why PD option is taken away? PD option also should have been there.
should have been there. PDA also would have been there. And
Yeah.
none of above. I thought like all of the above will be a possibility. If you
Yeah.
see in that particular way, I would have expected anything of these lesions would have been a possibility.
Okay.
Yeah, one more thing I want to add is in the history wise, you got a prominent murmur they detected by the patient attendant, I think. So can you enumerate the conditions where even the patient attendant can detect some abnormality in the heart? That is an important clue to say it.
A symptom that a patient may develop.
Sorry.
Are you asking if what are the symptoms that the parents might not, or only murmur?
No, you said that the parents noted some.
No, the hospital, the doctors, the people who are
Doctors, not the patient attendants.
Yeah.
Okay, okay. Then it is okay. Then the doctor detecting the murmur is not a great thing. So, because I understood in that way. Can you say what are the type of the murmurs or the type of the diseases can be detected by the patient attendant, like a prominent murmurs?
most pansystolic murmurs are can be felt perhaps as something different in comparison.
No, she's
most-
asking.
Namita, as Jyotsna said, in fact, I had a patient of VST brought by the ayah who was giving birth. She detected, and that's how the child was brought to me. So even the attenders or even the domestic helps who come to bathe the baby also can detect, And most often they are VSTs or PDS.
If you palpate some thrill-like thing,
Yes,
they also
yes,
feel it.
yes.
Anybody can feel it, and
Yes,
they may say there is
correct.
some abnormal sound which is coming. So
Absolutely.
or sometimes they may feel like a hyperdynamic precordial activity, and they feel that it's not a normal activity for a small child,
Yes.
and they may get it. So what she's
Absolutely
asking,
right.
how the parents will suspect that there is a possibility of heart defect when they even handle the child.
Correct.
Yeah, all high-pitched murmurs, like a small VSDs, which can have the thrills up to the extent of having a 5 or 4x5 of the thrill variety. So then you can definitely can be detected by the patient attendants also. Not only that, if you come to if it would have been an adult, then other possibility is the prosthetic valves. Prosthetic valve patients actually they come with that complaint that they're not able to
The click.
hear the prosthetic sounds.
Yeah.
So the another things which can be detected by the patient or the patient attendants is the prosthetic sounds. Yeah, please go ahead.
Can we go ahead with any more history, or
Yeah,
shall
sure,
we
sure.
start
Go ahead.
examination?
Yeah, but from the clinical history, Namita, what are your possibilities amongst all the possibilities what we discussed?
Ma'am, in acyanotic, it's a acyanotic heart disease, according to me, could either be a shunt physiology, small lesion, or a obstructive lesion, milder variety, like pulmonary
And
stenosis.
what do you feel the child became little breathless for last 2 months? He was absolutely okay, isn't it?
Yes, ma'am. I feel that it was, he has noticed it more. However, the severity is not very high, or it's non-progressive kind of a breathlessness. So I think it could have been just him kind of experiencing it more, or paying
Yeah,
attention
yeah,
to it.
Breathlessness for 2 months only, you take it and tell us what is the first possibility and the second possibility.
Any
Do the
complication?
ASDs become breathless
No,
at the
no, they
age of
don't.
10? No.
No. VSDs
Then-
perhaps having some aortic regurgitation could have symptoms or where they could develop breathlessness.
Yeah, so small VSD, then developing aortic regurgitation, coming with the breathlessness, that is fine. Okay, one possibility, good. Then,
Then progression of if perhaps it was an obstructive lesion, any progression in the severity of it could lead to breathlessness.
or, okay,
No,
but
out of the
anyway,
all the
large
si-
VSD developing Gussel's is ruled out because there is no past history of repeated respiratory infection. Okay, the
Yeah.
small VSD with the complication like aortic regurgitation can be thought of. Okay.
Even in the absence of the history suggestive of the shunt lesion, you wanted to consider the shunt as a first possibility. If you take all the three lesions of the ASD, VSD, and the PDA, who can become the much more symptomatic early in the earlier age group? Uncomplicated, you think? Don't think that associated with the syndromes and everything. Syndromic associations, even then any lesion can manifest as early as before the 2 years of age.
Significant shunt lesions of PDA and VSD will become symptomatic much more earlier.
PDA,
PDA.
more than an ASD, PDA.
PDA
Why
becomes
PDA?
first, PDA first, then VSD, and then ASD. Why?
Because the
That is in that order.
PDA has shunt flow in both systole and diastole, hence there is more increased pulmonary blood flow and more flooding.
No. PDA has got it directly the systemic aortic pressure pumping the into the pulmonary artery. So the pulmonary hypertension occurs much earlier in PDA. And in case of VSD, it is the LV to RV and then to the pulmonary artery. Okay.
Yes, ma'am.
But
Any other
invariably,
reason
because
other
this
than
is a small one. Okay, go ahead.
other than the
We'll
madam
go
said,
ahead with
any
examination,
other
ma'am.
reason for the PDA to become more symptomatic?
But she's asking any other aortopulmonary shunts we become.
No. I'm saying any other reason why PDA is more symptomatic than other shunt lesions. One thing, as madam already said about the direct systemic pressure transmission and PAH development. Is there any other reason? Is there anything to be related to the left ventricular diastolic pressure, endostolic pressures? Is there any myocardial ischemia is known to be then happen in the PDAs?
Very large PDAs where there could be reversal of the flow in the descending aorta, etc.
Not only that, the left ventricular strain is more in the PDA when compared to the other lesions. The VSD is decompresses into the RV. So you don't have that much of the pressure of the left ventricular strain. Here, whatever is the blood comes to the left ventricular, will have the left ventricular diastolic and pressure the rise. So there is a compromisation of the myocardial circulation, and the ischemia is a contributing factor. So that's why they become so much more symptomatic. Yeah, please go ahead.
Namita, another thing that you must remember is the PDA shunt, starts immediately after birth. And as a result, whatever the fetal pulmonary hypertension that was there, it is never allowed to involve, reverse. And as a result, that continues. That is another point. Okay. Go ahead.
Go ahead with examination, Namita.
Okay. On examination, head-to-toe examination, the child had normal features, no dysmorphic features were present. Anthropometric examination, the weight was 47.6, which is 50th centile for age. Height of 160 centimeters, which is also 50th centile for age, according to IIP charts. General examination.
Can we, Usha, can we just put a second quiz?
Yeah, sure.
So suppose the child has some kind of a syndromic features. Can we just put that slide, Usha?
I don't know. Already some people have asked.
If the equine faces is there, something has to be seen, no? Usha, this VSD, the slide is not gone. Stop sharing that and then come back to the first slides.
Monica, can you
Namita's
do that? Can you show the second poll question, Monica?
Yes, ma'am. Yes, ma'am.
Yeah, the second poll is if the child has facial features suggestive of Williams syndrome, I think everybody's 100%. By the time people have Googled it, Usha, you gave long time for
I
them.
know, I think question
So,
was
and-
No,
Okay,
it's okay. It's okay. Google Guru can be taken as assistant now.
yeah. So this has become Google has taken over.
Okay, Namita, you tell us what are the features of alpine
Then
fishes?
Williams syndromes and what are the possibilities?
Ma'am, I could not. Can you repeat the question, please?
No, what are
No,
the facial
suppose it
features
is
of-
an okay. Okay, go ahead there.
you can
Neha.
stop the poll, Monica.
But somebody has said pulmonary stenosis also, Usha?
Five people have answered.
And then we had to go like further. Anyway, Namita, you tell us what are the facial features suggestive of Williams syndrome?
Angelic features, smiling, large,
Large
Android-
fatuous lips and the mouth and
Vitulous lips,
malocclusion of the teeth, and then hypertelorism, and
hypertelorism.
then what else? I think she has to stop sharing that and go to the next slide.
Yeah. And now tell us which are the lesions which are associated with Williams syndrome. Namita,
supravalvular aortic stenosis. ma'am.
not only that, what are
Okay.
the other things which are associated with Williams, other cardiac and non-cardiac lesions associated with Williams syndrome? Very common when we see supravalvular aortic stenosis, we have to immediately see the other one.
Peripheral branch PS
So branch pulmonary artery stenosis, sometimes even
Yes.
renal artery stenosis.
What
And
is that
even
called as?
actually,
What syndrome is it called as?
and it's a combination
What
of
is Alagille syndrome?
Alagille syndrome. It is hyperbilirubinemia, so severe
Okay.
conjugated hyperbilirubinemia associated with persistent in peripheral branch pulmonary artery stenosis.
can this slide go out for Usha?
Which
This,
slide? Examination slide?
no, this poll slide.
Poll slide, I'm not seeing
yeah,
that.
okay.
Can you remove that?
No, we are seeing only the poll slide, it has not
Now
changed
it
at
has
all.
gone, Vijay Lakshmi. I think we have to remove
No,
it.
I'm getting the
Ma'am,
same thing. I don't know.
Monica, is it removed? Audience?
No, not it.
Yes, ma'am, it's
Not it.
removed.
Removed.
But why I'm seeing only that?
Maybe you should close it. I think panelists should
Yeah,
close
you
it
have to close it.
initially, ma'am. Yeah.
Can we go to the examination now?
Yes, Please go
Namita?
ahead.
Yes, ma'am. So general examination, normal no dysmorphic features. Anthropometry was normal. In pulse examination, the rate was 82, regular, normal volume, bilaterally symmetrical, no radioradial or radiofemoral delay. The blood pressure in the upper limb was 112 by 72 mmHg and in the lower limb was 116 by 70 mmHg. JVP was normal, not elevated. There was no pallor, cyanosis, clubbing, or icterus. In examination of the precordium, the chest
Oh, the pulse you did, what was the pulse you said?
82 per minute.
Okay.
Regular with
No
normal,
collapsing. Normal.
normal volume.
Okay. So there is no collapsing pulse, no white pulse pressure means your suspicion of aortic regurgitation is ruled out. And
And
PDA
even
is also ruled out.
Yeah, even PDA is also ruled out because your pulse pressure is not very wide.
Yeah.
You don't have a
So those
collapsing
two
pulse,
things are ruled out.
So
Okay.
these cases are ruled out. Okay.
Go ahead.
The chest was bilaterally symmetrical, slight precordial bulge over the left parasternal area. Apical impulse was visually appreciated in the fifth intercostal space in the mid-clavicular line. There were no other scars, sinuses, or dilated veins seen.
Okay.
On palpation,
Okay.
on palpation, the apical impulse was palpated in the fifth intercostal space in the mid-clavicular line itself. There was no palpable S2 in
So
the
is it within mid-clavicular or over the mid? Is it medial or over the mid-clavicular?
over the mid-clavicular line.
And that means it is laterally shifted.
Slight, yes.
Slightly. Okay. And what type is it? Is it LV type, RV type, or heaving, or forcible, or what it is? Hyperdynamic,
LV type of apical impulse, ma'am.
LV type. Okay.
No palpable S3 or S4.
Okay.
Systolic thrill felt over the left.
Where do you get the palpable S4? In which condition? And what is the significance?
What is the etiology? What is the origin of fourth heart sound?
Atrial contraction.
So it's a
Atrial contraction. So where is the atrial contraction powerful? Whenever there is aortic stenosis or supraaortic stenosis, at that time LVDP is raised. And when LVDP is raised, the LA also contracts forcibly. And that's how you get the S4. And if a palpable S4 is present, that means the gradient is more than 70. This is how clinically we used to suspect severity of the aortic stenosis. Okay, go ahead.
Systolic thrill was felt over the left parasternal area. There was no parasternal heave.
No, left parasternal area means second, third, fourth, where? Fourth. That means much lower down. Fourth is tricuspid area. Or it is little above tricuspid area.
In the left parasternal, yes, ma'am. Fourth and fifth intercostal.
No. Second will be for the pulmonary stenosis, and then the third intercostal will be for the infundibular stenosis, and the fourth will be for the VSD, and the fifth will be for the tricuspid regurgitation. So, which is the one you are telling? Which area?
Fourth.
It's in the third or fourth? Fourth. So, you are suspecting ventricular septal defect.
Yes, ma'am.
Okay, go ahead.
On auscultation, the S1 was normal with normal intensity. The S2 had a normal variable split with soft P2. No S3 or S4 was heard.
No, whenever you are talking about S2, don't say S2. Okay. Separately mention A2 and P2, and then whether they split or reverse split or what it is, the whole aspect of the second sound has to be described. Okay, go ahead.
So in second heart sound, A2 and P2 had a normal variable split with inspiration, and P2 was of soft P2.
P2 is muffled.
Not normal.
When you say soft, what do you mean by soft? See, soft is not the word that we use. No, either it is accentuated or it is muffled or it is normal. One of the three. Which one do you say?
I say normal, ma'am.
It's normal. Okay. So pulmonary second sound is P2 is normal. Okay, go ahead. Normal split, normal at the intensity. Okay, go ahead.
Murmur, a pansystolic grade 5/6 in intensity, harsh murmur heard best over the fourth intercostal space in the left parasternal area, which was radiating to the base.
Namita, what is the definition of pansystolic murmur?
Pansystolic murmur which starts immediately after the S1 and is heard all the way up to the second heart sound.
It has to start with the first sound and end with the second sound, and both have to be muffled. Now here you said the S1 is normal, you said P2 is normal, and then you didn't say that it is muffled.
Okay.
It always starts
with first sound. And pansystolic murmur is a soft blowing murmur. See, characteristically, the soft blowing murmur conducted to the axilla is a pansystolic.
Okay.
So would you like to change and make it as a long systolic?
No, ma'am. I think it is starting with the first and ending with the second.
What she is telling, Namita, then your first heart sound can be normal. Your first heart sound, because the murmur is so harsh and it starts with first heart sound.
Okay. The first and the second heart sound will be muffled. Okay.
Yes.
That's what we are trying to tell you.
Yes, ma'am.
Okay.
Yes.
So
And
if
now-
your first sound is normal, second sound is normal, then it should be a long systolic murmur. It
Okay.
starts with the first sound, just ends just before the second sound. That's all. Okay.
Okay.
And that could be crescendo, decrescendo, or it could be just decrescendo, whatever. So you have to mention that. Okay.
Okay.
Because the VST murmur can be crescendo, decrescendo. It can be only decrescendo.
It was
Whereas in transsystolic murmur, it remains the same intensity throughout. So that's the difference between the MR murmur and the VST murmur. This is the basic.
yes. Ma'am. I felt that the intensity of the murmur did not change throughout the heart sounds. In addition, there was no other additional mid-diastolic murmur heard over the apical area.
Okay. Okay. Why the mid-diastolic murmur is there in some cases? When does it occur and what's the significance?
A mid-diastolic murmur can occur when there is more volume overload and increased pulmonary blood flow which is cause increased blood flow across the mitral valve.
So it helps
So
you in
when does it occur?
quantification of the shunt. Usually what we mean is, if you have a large shunt, you always have a
Can
murmur
we
across
have
the
the audience question, ma'am, which you have made for this?
Yeah, please.
Monica, can you show
Whenever-
question number 4?
Whenever the shunt is more than 1.5:1,
Question number 4, ma'am.
then you can have the MDM
Okay.
because of the increased flow
Ma'am,
across the tricuspid valve.
There's a question about
Okay.
it, so we'll ask the
Okay.
audience. Question 4 for audience poll.
Not able to see. Oh, yeah. Okay.
Say, it's a 2-year-old child with a moderate size VSD, clinically 3/6 pansystolic murmur, as she said, and there is a MDM also at the apex. How much is the quantification of the shunt? Whether it is 1.5, 1.3, 1.5:1, 3:1, 2:1, none of the above, or all of the above.
Yeah, that's also correct. All of the above.
So what are the answers? Usha, we can't see the answers.
They are still answering, ma'am. Another 10 seconds.
Okay.
So most of the
Usha,
people
you have to ask, you have to add all of the above also.
Yeah,
actually there is a wrong
None of the
choice.
above and all of the above.
that will be, sorry.
Yeah, 5.
Yeah. So most of them have answered 1.5:1.
So it is more than 1.5:1, so it can be 2:1. it
Yeah,
can be 2:1.
that includes all of them.
So
Yes.
I think you should have given like correct.
All the
I
above.
can't give, but all of the above also. It is more
Yeah.
than 1.5:1.
But basically, it has to be more than 1.5:1. And below that, it is a very small one. So this is a moderate, and then that's a severe. Okay,
I think they have understood it.
good.
They've taken
The
different
audience are
actions.
very intelligent. Snehal will pass all of them.
I will pass on because they are simple questions, Vijayalakshmi. Anyway, with all these things now, Namita, now you have a history, you have a clinical examination. What is the most possible diagnosis? I will say we may be still wrong, but what is the most possible diagnosis?
Ma'am, according to the history, I would suggest a shunt lesion, small VSD is the most.
No, that shunt lesion and all that is in the history. Now you have finished your examination, you have found it there. So before we go for the investigations, you tell your diagnosis.
My
So
diagnosis
it is a congenital acyanotic heart disease. Then
a small VSD.
no, situs you have to tell.
Okay.
Situs,
Situs solitus levocardia.
solitus. Then
Situs solitus levocardia with
okay.
acyanotic CHD, small, most likely to be
No,
small
that has
VSD.
to come first, and then situs, and then that anatomical lesion, then physiological, and then complications. In that order.
Okay, ma'am. So a small VSD with left to right shunt, not in congestive cardiac failure.
Pulmonary hypertension.
with no signs of pulmonary hypertension.
No pulmonary hypertension.
No evidence
In
of
sinus
infective,
rhythm,
no evidence of infective endocarditis. Patient
no
is-
infective
all the
endocarditis.
things you have to
Okay.
tell complete. Can it be like a infundibular pulmonary stenosis, Namita?
Not with the examination. It
But
doesn't.
what is the point which
support.
goes against the infundibular pulmonary stenosis? What are the things which are against infundibular stenosis?
Against pulmonary stenosis, the type of murmur which we can hear, the pansystolic murmur.
No. There also the murmur will be harsh only. It will be slightly above the
Okay.
VST mark.
Even your
Okay.
skill has to be
And
less
then the
because this-
pulmonary component will be muffled or it will be less in intensity.
because again, as far as your clinical findings, valvular aortic stenosis, pulmonary stenosis are less likely. You are not hearing any click.
No click, yes.
So therefore, I am saying no valvular pulmonary stenosis, but even an infundibular pulmonary stenosis, whether it is likely.
And that thrill will be high up, in the second intercostal space. And that's the reason I asked you. The second, third, fourth, you have to be very clear where the thrill is best and the murmur is best heard.
Okay, can you show your investigations now, which will support?
Yes, ma'am. First, the X-ray.
There is an audience question, ma'am. What is the difference between pan and holosystolic murmur? Is it the same?
Yeah, pan and holosystolic murmurs are the same, but the long systolic murmur is different. So pan and holo start with the first and end with the second, and both first and the second sounds are muffled, and they have the same intensity throughout. Whereas in the long systolic murmur, first sound is normal, second sound is normal, and then the murmur, it is so long that it comes right up to the second sound, and at the end of the murmur, their intensity will come down. So that is a decrescendo or crescendo decrescendo murmur. Anything Snehal would like to add?
No, same, yeah.
Okay.
Yeah, Monica, go ahead. Sorry,
Ma'am,
Namita, go ahead.
The X-ray examination. X-ray, most likely AP view, with features suggesting
AP view or PA view?
the spine is visible much better.
No, that may be because of the hyper thing, no?
Okay, ma'am.
I mean, increased exposure. See, unless the patient is bedridden, you don't get the AP view.
Okay.
Is the patient sick? No.
No.
Common sense, no?
Yes, ma'am.
Namita, common sense is very important.
Okay.
I thought only I have less common sense. And I'm surprised that even Namita is joining my group.
I'm sorry, ma'am. Okay, X-ray chest, PA view, with
It's overexposed, and that's why the
spine is
thing
visible.
thin.
Okay.
Yeah, spine is thin. Is there kyphoscoliosis?
It is a little bit turned because
Yeah,
of the
rotated
entire
field.
X-ray is a little
Maybe rotated.
Rotated field.
What about the trachea?
the central trachea is central in location.
Okay, then that no rotation. If trachea is central, no rotation. Okay, then
with increased CT ratio.
And what is the cardiothoracic ratio? Namita, when you start a X-ray chest, whether it is well centralized, whether it is a AP or PA, what she was telling, then what is the heart size, which, what are the chambers you feel they are enlarged, and then move to the vascularity. There is a way on pattern
Yes, ma'am.
how we describe a X-ray chest.
Yes, ma'am. So the CT ratio is mildly increased. 0.6 is by 0.6. There is feature suggestive of mild right atrial enlargement, LV type of apex, and mild
no,
increase in
don't
the
say
pulmonary.
mild right atrial enlargement. If you say right atrial enlargement, then I'll ask you, how do you measure the right atrial enlargement?
Yeah, how do we measure the
From
right
which point to the which point you measure?
Ma'am, drawing a line from the center, the maximum
From the spine,
convexity.
you have to, from the center of the spine to the right border.
Right.
So how much it has to be to call it as a right atrial enlargement? More than?
More than 1.5.
No.
Opinion poll.
Your opinion poll. Ask the
Yeah, just quick
candidate.
answers we want. what is the definition of a right atrial enlargement on the X-ray? So you draw a line
Radiology.
from mid of the sternum, midline from the sternum, spine, and lateral border of the right atrium, and
How much?
how much it is significant, how much
She is saying
centimeter-
1 point, yeah. And apart from that, there is another parameter, how many intercostal spaces it is occupying. That is also important.
yeah.
Usha, the questions?
No
Yeah,
answer.
yeah, we have written, yeah, we got answer 3, 4.5, 5, 5.5. But if I am correct, it is more than 5 centimeters. If you are mid sternal line or a mid spinal line to the most lateral border of the on the right side.
And
I
some
think it is
answer
2.5
3
centimeters. Am I right or wrong, Usha?
And 3 intercostal space they should occupy.
Yeah,
2.5.
3
2.5.
spaces or 5.5 centimeters
5.5.
from midline.
5 or 5.5 most.
I remember as 5.5, ma'am, from midline, or 3.5 from lateral sternal border.
And this is not even 3 or 4.
Huh.
And
But-
you have to literally mark it and measure it. You know?
Actually, you have to really mark it in the midline and then measure it the most lateral on the right side, and then measure it. For the examination, you have to measure it. Namita,
Yes,
you had enough time to measure actually.
Okay, ma'am, sorry.
And one more thing, what about the cardinal angle? If there is a significant LA
Yeah, what is
dilatation, then the
carinal angle?
cardinal angle will be wide.
No,
But here it is not.
yes, ma'am.
What does that tell you?
Okay.
It is normal. What does that tell you? Again,
It says that there is no significant LALB enlargement, which will
Okay.
cause the left atrial enlargement.
Namita, watch your words. You said P2 is normal, and then you say right atrial is dilated. How can you explain?
how can you explain?
And then
Suppose
you
the
said
right
there is no
atrial
parasternal
dilatation
here.
also. How do you explain right atrial dilatation in small VSDs?
If there is an indirect LVRA shunt, that could lead to some volume overload causing right atrial enlargement.
So sometimes if you have a Garbodi-like shunt that your VSD jet, it
Yeah,
goes through
that
the
is the
transverse
most
wall
important.
and goes to the right atrium directly, there may be a right atrial enlargement. So you have to explain what
Yeah,
you
that is exactly what I wanted you to answer.
Yes, ma'am.
In a small VST, if the right atrium is enlarged, that means it is not a regular VST. It is a Garbode shunt from the LV to RA. And that's why you get the RA dilatation. Because when the pulmonary pressure is normal, P2 is normal, but still RA is dilated. So that can happen in a Garbode shunt.
Can we
Okay?
go ahead,
So
ma'am?
you must be smart enough to answer that.
Usha, you keep on pushing us when we
Yeah,
stop at one point.
it's almost
Yeah,
45 minutes up. Yeah, can you
Yeah,
go?
yeah.
to-
Okay, go ahead, go ahead.
Fine,
We have
go
come to the end. Go to the ECG now. I mean, either a plethora. What is the definition to call it as a plethora?
On X-ray, ma'am, more than
Yeah.
2/3 of the vascular markings are reaching more than 2/3 of the lung fields.
No. What about the end-on views, my dear? How many end-on views are required to call it as a plethora?
And on vessels more than 5.
You want to ask the audience? What is the answer from the audience?
End on appearance in 3 in one lung and 5 in both.
Yeah.
Yes,
Yeah.
correct. Okay, go ahead.
Yeah, I think just go on ECG now. Yeah, just tell what is the most important feature which may like substantiate your diagnosis.
ECG suggestive of sinus rhythm with normal QRS axis, increased R waves and seen in the left-sided precordial leads with T waves, prominent T waves, and Q waves.
Is there a Kaas-Borshel phenomena or not?
No, ma'am, there is no biventricular
It's not.
hypertension.
So that means the large VST is ruled out by the ECG.
Yes,
Okay?
ma'am.
Okay.
Should I go ahead with the next?
Okay. Next, echo.
Yes, ma'am. Here we can see the apical 4-chamber view. showing
Mhm.
a mild LALV dilatation, no significant large LALV.
No, LA is smaller than the RA. Here you can see that. LV, okay, but not LA. Look at the comparison of the LA and RA.
Yes, ma'am. RA
Okay.
seems to be slightly more.
Yeah.
Yes, ma'am.
Yeah. The LV is dilated. Okay, then.
Here we can see the color interrogation.
Yeah,
of
color Doppler shows.
we can see a VSD, perimembranous mostly.
Is it a high muscular or it is inlet, or how do you make out whether it is a perimembranous or high muscular or subpulmonic? How do you make out?
In the parasternal short axis view, depending on the location.
That is short axis. Okay.
Here the VSD shunting left to right.
Yes.
And you see that there is a left to right, but there is a significant restriction. Maybe it was a big VSD to begin with, and it is getting.
Is there a TR? Is there a TR?
Yes, ma'am. I'll show it in the next video.
Yeah, partially restricted
Okay.
by the septal.
No, because I could see the TR there. No, that's the reason I'm asking.
Yes, ma'am. Here we can see the more.
When does the TR occur in the VST?
The because of the indirect Gerbaudet effect causing the LV dilation.
No. One is Gerbaudet. Type 2, it will pass through that. It looks like the TR.
Yes,
But
ma'am.
when the septal leaflet tries to close the VST, and then at the cost of the TR it occurs. Okay.
Yes.
You see a
So
mild
if the
tricuspid
aortic cusp
regurgitation.
prolapses, it causes AR. If the septal leaflet tries to close it, then it causes the TR. So both the TR and AR should be looked carefully when you are doing the ECMO. Okay.
Yes, ma'am. Here we can see a much more better view where we can see the tricuspid regurgitation.
Yes. Both the jets are seen.
Yes, ma'am. So the parasternal short axis view showing the
Okay.
VSD.
And now you see a significant tricuspid regurgitation. Actually, the VSD jet traverses through the tricuspid wall. orifice
Yeah,
and
look
into
at
the
that.
TR.
Look at
And that
that.
is-
There is an
that
aortic
explains
regurgitation too.
That explains your right atrial enlargement, what you are seeing on the X-ray.
Yes.
Parasternal long axis view showing the VSD with the left to right shunt. Like
But
yes, ma'am.
here AR is not seen because you know what has happened is the cursor is away. It should have kept here. Then you could have seen the AR also if it is there.
There is no
Yes,
AR,
ma'am.
isn't it?
No, ma'am. Actually, in the other views,
There is
we
no
could not see a significant AR.
Okay.
And what is the
But the
gradient to
TR
cross
is
the
there. TR is there. So
Yes.
you must measure the gradient across the VST. I mean, in the sense, how much is the gradient? The Doppler study. Suppose it is 64. What does it mean?
It is a small VSD which is restrictive with the
Okay. So how do you calculate the peer pressure by the gradient of the VST?
with the tricuspid regurgitation with plus
No,
right.
like
no,
through the
no,
VSD jet.
no.
Through the VSD jet.
With
Suppose
the
you have a
VST gradient, how do you tell the peer pressure? You have the aortic pressure, you minus the gradient across the VST, and you get the peer pressure. Okay.
Okay.
The TR jet also you can get the peer pressure. So both can be compared. Okay.
Sure, can we just stop here? Will you just tell us?
Yeah, you want to ask our
How do you
audience?
manage? How do you manage?
How do you manage this child who is 12-year-old and with this kind of anatomy with a moderate VSD getting restricted by the septal tricuspid leaflet causing tricuspid regurgitation with a mildly dilated left atrium, left ventricle and right atrium as well. No pulmonary hypertension.
Yeah.
Since
And the right atrium is because of the TR. Okay.
Yes,
Okay. Now, what else you would like to see?
so
Whatever Usha has shown, I'm not completely happy. I would like to see something else. What else would you like to see? Whether there is a rim of septal tissue below the aortic valve. For the device closure, you have to have at least a bit of tissue. Of course, perimembrane also we close, not that we can't. We can close perimembrane also, but if there is a tissue, it is much easier to close with the device. So what is the size of the VST? That has not been given to us. Usha, what is the size of the VST and is there a tissue? In the
Namita,
apical 5-chamber, yeah.
Namita should tell. It's her case, ma'am.
Okay, okay, Navita, tell us.
It's around 4-5 millimeters, 4 millimeters or something, Namita.
Yes, ma'am. I think it is 4.5 millimeters VSD.
4.5. So that will go for the device closure and not the surgery. Okay.
Yes, ma'am.
Though the TR is there
audience
and that will
question.
come down once the jet goes off. Okay.
A couple of questions for the audience, and then we can. Yeah.
Go ahead with the talk. Yeah. Dr. Monica, can you show 6th question?
Yeah, well done, Monica, Namita.
Thank you, ma'am.
Yeah. Suppose we have a 6-month-old child with a large VSD and had a heart failure, which is the drug which is actually should not be given amongst all 4: furosemide, enalapril, sildenafil, digoxin, which is relative contraindication and it should not be given. So large VSD, pulmonary hypertension with heart failure.
So I think the word contraindicated is very important.
So large VSD with pulmonary hypertension, and usually some of these drugs are given, so which should not be given amongst all 4.
Ma'am, while audience poll is going on, there was a question by one of the attendees. How do you differentiate LV apex and RV apex?
On the X-ray, isn't it?
No, clinical examination.
So always in the LV apex, usually what we say is the lateral, the shift is lateral and outward. Is usually a left ventricular apex, and right ventricle is just a lateral rotation but not outward.
Yeah. And a discrete is LV apex and diffuse.
LV apex is always a discrete LV apex, maybe many times tapping or hyperdynamic. RV apex is always a diffuse LV apex.
Yeah.
And one more thing is in RV, there is a lateral retraction, and whereas in case of LV, it is a medial retraction. So these are the 3 features which make you to make the difference.
Yeah. Can you stop the poll?
Actually, when we see the management, we always give furosemide. Many times we give enalapril. Many times we give digoxin if there is significant tachycardia. Most of the time, or always, sildenafil should not be given in this kind of a situation because that will increase the shunt. That will reduce your PVRI. The left to right shunt increases and the heart failure will increase. So all the 3 drugs can. Usually that's a kind of a management, medical management, furosemide, enalapril, and if required, digoxin, but sildenafil should not be given.
Should not be given. Very valid point.
Okay, thanks, Dr. Namita. That was a very nice presentation and very beautiful echo images. So we have a short talk by.
It just
well done, Namita.
Thank you, ma'am.
We have a short talk on approach to acyanotic heart disease by Dr. Snehal, ma'am. Ma'am, can you start sharing your PowerPoint?
I started sharing your screen sharing already. I am sharing the screen.
Ma'am, PowerPoint, you should make it full screen and make it show.
Yeah.
Right, show?
Yeah. Is it seen now?
Yeah, it is seen, but it's not slideshow.
No, make it full screen. Snehal.
Yeah, I am doing that.
Oh,
yeah, it's seen, ma'am. Huh.
Yeah. So it's a quick couple of things what we were already discussing.
Ma'am, it's back to. It's again not in show mode.
Wait a minute. But yeah, is it okay now?
Yeah, it's fine now.
Yeah.
So first thing, as we have discussed, when it is actually a big child, whether it is a, some of the slides have been shared by Dr. Anita, so her logo is there. So is it we have shared completely all our slides together actually. Is it a congenital heart defect? So in infants and children, CHD is more common. In older children and adults, it can be CHD or rheumatic heart disease. If the murmur is parasternal, congenital heart defect is more likely. And then we don't go into the presence of cyanosis. And the right approach is history, physical examination, X-ray test, and ECG. And always listen to what the parents say, because they really give you most of the time the diagnosis. Many times the how do we clinically recognize good history, actually, especially in smaller kids, feeding difficulties, failure to thrive, tachypnea, history of cyanosis at rest or crying sometimes, and see you get any other symptoms. And one of the symptom actually what we get is aphonia. These kind of symptoms actually they suggest the heart failure. Just see what is the general appearance, whether the child is tachypnic, as I said, aphonia sometimes because of the dilated left atrium which compresses on the recurrent laryngeal nerve. Child रोने के time आवाज नहीं आता है. This is a very common symptom of a child with a very large left to right shunt. Just see for the weight, height, and physical development in a child. Usually, like in adults, we do not get like JVP and edema, those kind of symptoms. In fact, in children, we do not use NYHA classification, especially in infants, we use modified Ross classification, and just be little sure about how do we classify the symptoms as far as the Ross classification. And we don't get this kind of a signs and symptoms like edema, lung crackles, which are very uncommon. Very common, like just see whether the child has any kind of a syndromic association, because we know Downs is with aviceptal defect. If you have William with supravalvular aortic stenosis, we have Noonan's, it is pulmonary stenosis. So just see whether the child has any syndromic features. We discussed about the chest X-ray, see the location of the heart, whether cytosolitis inversus, whether there is any chamber enlargement, heart enlargement, whether it is the right or left aortic arch. See for pulmonary vasculature, extracardiac structures. And on ECG, see whether you have a right ventricular or left ventricular hypertrophy, depending upon, I won't go into the details of the criteria, but that will tell us depending upon which chamber is at stress and what hypertrophy you see. So in acyanotic, mainly we have two types of lesions. One is large left to right shunts at the atrial level, ventricular level, or a great vessel level, or obstructive lesions, either aortic stenosis, pulmonary stenosis, coarctation. So we see a cyanotic child in an older child, like this 12-year-old child, the common defect which are expected to this survive. So without much problem are ASP, mild aortic stenosis, pulmonary stenosis, VSD, PDN, coarctation, and these were the lesions which we were discussing. Sometimes some uncommon defects which can survive without much problem to this age, they are the Epstein's abnormality and small size AP windows. So by and large, we have this kind of a symptoms, heart failure, then you have a large shunts, you have just murmur but no much shunts, we have small shunts or mild or moderate aortic stenosis, pulmonary stenosis. If you have palpitations, usually they suggest there is either a valvular lesion, there were a volume overloaded shunts, they also can give palpitations. Chest pain, it very little classic about severe aortic stenosis, which can happen even in syncope. If you just find an accidental hypertension in a child, it may be due to severe coarctation, which was undetected. And seizures, if the child has, it suggests a complete heart block. As we discussed about the extracardiac abnormalities, so a cyanotic heart disease, either they are left to right shunts or obstructive lesions. So just see whether the child has failure to thrive, the precordium is hyperdynamic, there are signs of heart failure, murmur, systolic plus diastolic. Diastolic is the flow murmur across the mitral wall. If there is cardiomegaly, increased pulmonary blood flow, these all suggest you for the left to right shunts. As far as the obstructive lesions are concerned, see how is the precordium, is there a ejection click, no much cardiomegaly, but there will be a poststenotic dilatation of the arteries, either it may be a pulmonary artery or it may be aorta. So these in general, we have a clinical assessment about the lesion. And I won't go into the detail, usually how the atrial septal defect presents. It's always or most of the time, these are picked up on an incidental. Sometimes these full health examinations happen and then they find a murmur, they send to you, and most of the time it's underlying ASD. By and large, VSDs or symptoms depend upon how is the size of the VSD. As she said, we discussed about this case, If it is a small VSD, may not be any symptom, but a large VSD will be very symptomatic in early infancy. And moderate VSD usually is symptomatic between 6 months to 1 year of age, and they need to be followed carefully. So how do we assess ASD, VSD, and PDA? Actually, the second heart sound. ASD we know wide fixed, VSD is variable, PDA is normal. P2 again depends upon the size of the shunt. Most of the time, VSD and PDA has significant pulmonary hypertension. ASD may not have severe PH. Murmur, ASD murmur may be nil, or you may have a mid-diastolic murmur in the tricuspid area. Again, it's a murmur across the tricuspid wall, and sometimes flow murmur across the RV outflow tract. VSD, we have a systolic murmur. PDA, we have a continuous murmur. Same way, X-ray chest, right atrium, right ventricle are enlarged, small size aorta. Dilated LA and LV, aorta is normal. Here dilated LA and LV, but aorta is always dilated. At the same time, ECG, you have a volume overloaded right ventricle, so always have right axis deviation, incomplete right bundle branch block. You have normal axis biventricular enlargement, what you see especially in V3 and V4. You have normal axis and mostly a left ventricular enlargement. So these are some of the very classical X-rays about the atrial septal defect. You have dilated right atrium. Ventricular septal defect, you are dilated left ventricle, and PDA, you always say dilated ascending aorta, and you may see a knuckle here. And we have already talked about the clinical assessment of quantification of the left to right shunt in the post-tricuspid shunt. So as we discussed, if the shunt is more than 1.5 or 2:1, you have cardiomegaly, heart failure, suggests usually a large shunt. S2 is split, wide variable in large shunt, split narrows as the pulmonary vascular resistance increases. And if you have a pulmonary hypertension, you know always the louder the murmur, smaller is the shunt, so duration may be shorter, but if the PVR starts increasing with severe pulmonary hypertension, again your shunt murmur decreases. And X-ray test shows degree of cardiomegaly and pulmonary plethora. Again, you see, I think the X-ray what she showed today was like this. You have a moderate size VSD, not a very large VSD. But if you have a large VSD, you have a cardiomegaly. Even if you have a carinal angle which is wide, suggests a left atrial enlargement, and see the plethoric lung phase. See the typical X-ray of a child with a large VSD, you have this biventricular enlargement. See this RNS waves in V3 and V4, Katz-Wachtel phenomenon. A typical ECG of a large VSD. Here you see you have a kind of a right axis deviation. You see 1 and AVL. You have incomplete right bundle branch block. The ECG is very suggestive of a ASD. Here again, actually we have put another question. If you have a leftward axis with incomplete right bundle branch block, always suggest a ASD, but ASD location will not be ostium secundum. It is more of a primum kind of a ASD. And sometimes you have like what we call it as a wandering P waves, or a P wave axis is not normal. So there's a possibility that you have ASD, but ASD is in the location of a sinus stenosis defects. As compared to, if you see the obstructive lesions, they are either aortic stenosis, pulmonary stenosis. Suppose they are mild lesions, you don't have any specific symptoms. You have a heaving chest, but no cardiomegaly, loud ejection murmur, ejection click for valvular stenosis. And depending upon whether you have a AS or PS, you have a ventricular hypertrophy. And as I said, this is a patient of pulmonary stenosis, and these are the aortic stenosis. How do you differentiate the site of the murmur? Valvular AS, second right intercostal space. Valvular PS, second left intercostal space, sorry. Ejection click is a constant in aortic stenosis, inconstant in valvular stenosis. S2 is a narrow split or a reverse split. Here a wide variable split, and P2 is always soft. In valvular AS, you have a heaving apex. Your PS, your sustained heave at the left parasternal border, always it suggests the right ventricular hypertrophy with a pressure in the right ventricle is significantly elevated. Typical X-ray of valvular AS, see a dilated ascending aorta. Valvular PS, you may find a dilated pulmonary artery. So this is a severe pulmonary stenosis with significant right ventricular dysfunction. You see how is the right atrial border also significantly enlarged. Maybe there is associated severe tricuspid regurgitation. So we have a left ventricular hypertrophy with a strain kind of a pattern, suggests aortic stenosis. You have a right ventricular hypertrophy with strain pattern, suggests pulmonary stenosis. Actually, coarctation is always a clinical diagnosis, and I think all the examination should always start with a palpating the upper limb and lower limb pulses, and invariably it is missed mainly because nobody palpates the lower limb pulsations. So it's always a clinical diagnosis, and if you see the clinical presentation, I think they are bimodal kind of a presentation. If you have severe aorta in a severe coarctation of aorta in a newborn or small infants, they may present with low cardiac output and even shock-like condition as soon as our duct closes. But if it is not very severe or mild to moderate, they keep on we follow them or they're accidentally detected because somebody just takes the blood pressure and they detect that there is a coarctation of aorta. I won't go too much of a pulmonary hypertension thing. As we discussed pre-tricuspid shunts, there is a gradual increase in the PA pressure. So the PA pulmonary vascular resistance develops quite late as compared to if you have a direct aortopulmonary shunt or a ventricular septal defections, your the pulmonary vascular disease develops quite earlier. So as I said, I don't go into the nothing, but how we clinically differentiate between a hyperkinetic and obstructive pulmonary shunts. In hyperkinetic, usually heart size is large. Hyperkinetic parasternal impulse. S2 is wide and fixed or a variable. There is a shunt murmur and there is a flow murmur. Whenever the PVR develops, pulmonary vascular resistance develops, the heart size starts actually decreasing. The P2 is fixed split or short or absent even. And these are some of the X-rays, how the hyperkinetic pH X-ray looks. And when it's an obstructive PA pulmonary hypertension, you don't see any vascularity in the lungs. So these are some of the things. And some uncommon causes of pulmonary hypertension we need to look into, especially if they present very early, like in early infancy, as soon as the neonatal period goes down and then the pulmonary vascular resistance comes down, then these are the AP windows, sometimes left ventricular inflow obstruction, RPF from ascending aorta, pulmonary venous obstructions. So take home message, a systematic clinical evaluation, X-ray test and ECG are very important, and echocardiography. Actually, you should always make your diagnosis before you keep your probe. You have to have your own assessment, what kind of a lesion we are dealing with. Do you feel it's a small, large, severe? And depending on that, your echo actually just substantiates your clinical finding. That's what I say. So thank you very much, everyone. Usha.
Thank you, ma'am. Thanks a lot for that lucid presentation. And for emphasis on the fact that clinical examination is very important, because people feel that echo will give all the complete diagnosis, whereas echo is as subjective as clinical examination. And unless we don't have a certain idea as to what we are expecting, echo also can give wrong results. Thank you, ma'am. Thanks for joining us.
Yeah, I agree with Snehal and Usha also, because I always tell, be Indian, touch the feet, you will never miss the diagnosis of coarctation. So that's how, one has to, otherwise, you may miss coarctation if you don't feel the pulse in the lower limb. And Snehal, that was nice seeing you after a long time.
Yeah, nice seeing
and
you.
Usha, Usha,
Nice to see you,
very
ma'am.
nice
Sorry, I
questions.
was
And
silent here.
I would just like to say that recording will be available shortly on Wincar's website. Thank you.